Hi, everyone. I am Grant Mitchell. I've been a member of the board of directors for Crohn's Colitis Canada for the last 6.5 years, ending this Saturday, May 1st. On behalf of the board, I welcome you all to this presentation, the latest in a long series of educational programs on IBD and COVID. I've attended most, if not all of them, and I think they've been a tremendous source of information and comfort. I was diagnosed with ulcerative colitis in 1994, and I had pelvic pouch surgery in 2000. I'm currently on a biologic treatment program. I'm also in an age category where the existential threat of COVID is particularly significant. I'm looking forward for any information I can find on vaccinations and IBD. I suspect many of you are in comparable situations. The vaccine programs are rolling out and everyone is excited at the prospect of a healthy return to normal life. Hopefully, by the time our annual Gutsy Walk occurs on June 6th this year, things will have improved dramatically from where we are today. We hope you will join us as together we walk to stop Crohn's and colitis. We've been happy to be the organization that you've turned to for information and support. We are so grateful for all the people and organizations that continue to come together to help the IBD community. Because of you, we were able to sustain important research work, and because of you, we can continue delivering programs like these webinars. The pandemic has lasted longer than any of us could have imagined, and all of us are looking forward to going back to pre-pandemic times. One of our signature and highly popular pre-pandemic activities has been our summer camp. This year, we are not holding an in-person event and instead are offering the next best thing. During the week of August 9th to 13th, 2021, children and youth between the ages of 9 and 17 have the opportunity to meet fellow IBDers, network, and to enjoy camp activities virtually. So if any of you in the audience knows a child with IBD between the ages of 9 and 17, please pass on this opportunity. As always, this information and the webinar recordings can be accessed on our website at crohnsandcolitis.ca. With that, a huge thanks also to our task force who continues to meet to discuss policies and recommendations necessary for our community. Thank you to today's panelists, Dr. Ann Famhui and Dr. Charlie Lees, who's joining us in the middle of the night in the UK to help us with our program. And of course, much appreciation to our fantastic moderators, Dr. Gil Kaplan, Professor of Medicine, University of Calgary, adult gastroenterologist and epidemiologist, past chair of the Scientific Medical Advisory Council of CCC, as well as Dr. Eric Benchamal, professor and pediatric gastroenterologist at the Hospital for Sick Children and University of Toronto, chair of the Scientific Medical Advisory Committee of CCC, as well as Crohn's and Colitis Canada board member. Thank you and enjoy the program.
Thanks very much, Grant. It's great to be here again today. Unfortunately, in the middle of the third wave of the pandemic, which I don't think we expected to be in the middle of 4 weeks ago. Well, some people expected it. Obviously, our politicians didn't expect it all that much.
Yeah, and the fact that it's worse than the previous waves, and it's just being extremely frustrating. Our last webinar that we did in March was our 1-year anniversary of doing these webinar series, and you know, I think we all, including like Eric, you and I, thought we would be in a much more promising place right now than where we are. And I think that's the whole point of today's webinar, is to try to answer some of these challenging questions that the IBD community has had around vaccines, when to get them, how to do it, and what's going to happen as these are roll out over the course of the next few months.
Yeah, that's right, Gil. And I think that, you know, while vaccines are clearly our way of preventing the next wave of the pandemic, as we see in the UK, in Israel, and also even in the US, who have avoided a third wave of COVID-19, it doesn't change the fact that right now we're dealing with a third wave and we're not going to be able to vaccinate enough people quickly enough to prevent it from spreading. So really all of those recommendations that we've given over the past year still hold true, especially now. And it's really a matter of trying to stay home as much as possible, avoiding your contact with other people, even if you're vaccinated, even if you've been lucky enough to be vaccinated with 2 shots, but especially if you've been vaccinated with only 1, you really still need to stay home and protect yourself and protect your community. But we'll talk more about that later.
Yeah, I mean, today's is jam-packed with 2 phenomenal speakers who are covering a huge number of questions that I've been asked to CCC directly about the vaccine. So I'm just going to do like a very short, under 5-minute, just kind of overview of where things are at and to kind of set up the presentation. And then Eric, I'll call you back in about 5 minutes from now. And so I just wanted to start by sharing this figure. Those who've watched the webinars before have seen this graph grow over time. And as of April 28th, when we kind of crunched the numbers yesterday, nearly 150 million people being diagnosed with COVID-19, over 1.2 million in Canada alone. The Secure IBD Registry, an international database of individuals with IBD who've tested positive for COVID-19. On March 19th, there were just 21 people in that database. Today, nearly 6,000 people have been reported throughout the world. And we can clearly see 3 waves of the pandemic in Canada. And this graph shows the daily number of cases of COVID diagnosed over the past year in Canada. The first wave of the pandemic between kind of March and May of last year, daily cases were exceeding roughly about 1,500 diagnoses a day. And you could see in the summertime, they kind of waned down dramatically and then picked up again in the fall. And at the peak of the second wave, which was in January, there were about 8,000 cases a day being diagnosed across Canada. And the valley of the second wave, where things had kind of leveled off, we were still diagnosing around 3,000 new cases a day of COVID-19. And that is higher than the peak that we saw of daily cases during the first wave back in the spring of 2020. And as you can clearly see from this graph, Canada is currently in our third wave, which is the worst to date, to nearly 10,000 cases a day across the country. Driving this number down will depend on what we do collectively and how quickly Canadians become vaccinated for COVID-19. So I just wanted to address this question. Why does the virus spread throughout society, and how do we stop transmission? In other words, why is SARS-CoV-2, the coronavirus that causes COVID-19, spreading so quickly throughout Canada? How infectious a virus is, or how easy it is to catch, is defined by the virus's reproductive number. The reproductive number means the average number of people infected by one sick person in the absence of interventions to control the virus when the whole population is susceptible to infection. Now, when that reproductive number is below 1, then one infected person on average will infect less than one other person, and the virus declines throughout the population. When the reproductive number is equal to 1, then one infected person on average will infect one other person, and the daily number of cases in the population remains stable over time. However, when that reproductive number exceeds 1, infections increase through the population. Now, features of SARS-CoV-2 that make the virus highly infectious include its mode of transmission, which you understand is both droplet and airborne, its incubation period, which is roughly about 5 days prior to symptom onset, and the fact that many people who are sick with COVID-19 are either asymptomatic or just mildly infected. They don't realize that they're sick when they're transmitting it. And probably one of the most important factors is just the novelty of SARS-CoV-2, which makes the entire population susceptible to it. Now, without any interventions to control the spread of SARS-CoV-2, its reproductive number is 2 to 2.5, double that of seasonal influenza. This means that left unchecked, one infected person on average infects between 2 and 3 other people. Then those individuals infect 2 to 3 people, and eventually you'll witness the exponential growth as seen in this animation. In the absence of natural immunity to a virus or the availability of vaccines, the only way to drive that reproductive number of the virus down is to institute public health measures such as hygiene, physical distancing, masks, personal protective equipment, and staying home. The results of these interventions is to drive the reproductive number below 1 by preventing contact between individuals, one person who's infected and one person who is susceptible to infection. As displayed by this figure, avoiding contacts means that fewer people are infected and infect others around them. Now, comparing our third wave to our first wave, 2 new factors are influencing the reproductive number of SARS-CoV-2. First are variants of concerns, mutations of SARS-CoV-2 that increases the transmissibility of the virus. These variants make the virus easier to acquire and in turn raise that reproductive number of the virus. Counterbalancing the pressure of new cases is the escalating vaccination of Canadians from those on the front lines to those who are most vulnerable to the general population, as well as ongoing public health measures that continue to protect the public from infections. Now, this tug of war between variants and vaccines, as well as the actions of the public to prevent transmission, will define the height of subsequent waves of COVID-19 in Canada and ultimately the waning of this pandemic around the world. I'm just going to invite Eric to come on and talk about vaccine safety.
Absolutely, and this is sort of a follow-up from last week's presentation. Let me just get my slides up here and share my screen. All right, so you should be able to share my screen. You should be able to see my screen rather. So a little bit of an update from last month's presentation where we discussed vaccine rollout and particularly the AstraZeneca vaccine and the concern about clots. I think it's important to follow up and give you additional information if you haven't been following closely. A lot of information has been coming very quickly. So I think a nice summary is in order at this stage. So first, the good news, we are now at 31%, as of today, 31% of the Canadian population has received at least one dose of any vaccine, which is excellent news. It's coming quickly, as I mentioned. We're still only at about 3 or 4% who have received 2 doses or are fully immunized. But we know that public health has really focused on getting as many people as possible 1 dose under the assumption that most people will be covered to a certain extent by 1 dose, and it reduces the load on the hospitals and reduces death rates. So how are we doing compared to other countries? Better, I think, is the bottom line compared to last month. We're not at the stage of the United Kingdom or the United States. However, we are running a bit ahead of the European Union at this stage. And when we look at the number of doses administered per day, which is really the number that we're most interested at this stage, is how many doses are we getting into arms every day? We have improved dramatically. So we're now at the stage of administering as many doses every day as the United Kingdom and the United States, and a fair amount above the European Union. Now, obviously, we know the United States and the United Kingdom are ahead of us in terms of when they started and how quickly they administered it before. But at least we're getting to that stage of being almost at 1 per 100 doses administered every single day in Canadians. As we mentioned at the last webinar, there are 4 vaccines approved by Health Canada for use in Canada. The Pfizer and Moderna vaccines, which are mRNA vaccines, and then the AstraZeneca and Johnson & Johnson vaccines, which are adenovirus vector vaccines, non-replicating adenovirus vector vaccines. We talked a little bit about the differences between those types of vaccines about 2 months ago. If you want to look up the video, you'll learn more about how those vaccines work and what the differences are. But I wanted to really focus on the adenovirus vector vaccines and the risk of side effects today, particularly the risk of blood clots, which you may all have heard of. We're grateful that this week, Johnson & Johnson, we will have a few 100,000 doses available, and that's a 1-dose vaccine. So that's going to start to be administered in Canada. It's being administered in the United States already. So first of all, we had some questions for people who registered about side effects and how people felt not so great after either their first or their second vaccine. And this is sort of the numbers that we're seeing. And there was actually a study released yesterday detailing the difference in side effects between the mRNA vaccines and the adenovirus vector vaccines. And there are differences. I think the bottom line is that the side effects that you're most likely to experience are shown here on the left. Pain at injection sites is certainly a big one. I couldn't lift my left arm after my first dose. But redness, swelling, headaches, fatigue, chills, even fever is not uncommon. I think what we've learned is for the Pfizer and Moderna vaccines, your risk of side effects is higher with the second dose, whereas for the AstraZeneca vaccine, it seems like people are having more side effects with their first dose. So, I mean, I think the bottom line is the side effects are fairly mild and they do go away within about 24 hours. But I would prepare, if you're going to get these vaccines for the next day, sort of prepare potentially not to work if you're feeling really unwell, particularly after the first dose of AstraZeneca. And another question came in from the audience was, do people with biologics Are they more prone to severe side effects than people who are not on biologics? And as far as we know right now, the answer to that is no. There doesn't seem to be any indication that they're at risk for more severe side effects at this list. So let's talk about the risk of blood clots a little bit. We talked last time. At the time, we had just started hearing about the risk of blood clots in people getting the AstraZeneca vaccine, and the Europeans had paused the vaccines. We now know quite a bit more. So it seems like the blood clots associated with these vaccines, with AstraZeneca and likely with Johnson & Johnson, are not the typical types of blood clots you would get from, for example, being on the oral contraceptive pill, the birth control pill, or in people with high blood pressure. This is a different type of blood clot, which is a reaction to the actual vaccine. And it's an immune reaction that causes the problem. Very similar to a concept that we've known for decades now, something called heparin-induced thrombocytopenia, or HIT. People who are on heparin, a very commonly used blood thinner, develop an immune reaction to the heparin. They get antibodies to a component of their platelets, which is one of the clotting factors in your blood, which then result in activation of the platelets and clumping, which then result in blood clots. And it seems like this type of immune reaction that is happening with heparin is very similar to the type of immune reaction that is happening with the AstraZeneca vaccine, as has been described now in multiple papers that have been published over the last couple of weeks, where you get an activation, you get an antibody reaction, an antibody to what's called platelet factor 4 on your platelets, which result in clumping of your platelets, a reduction in the number of platelets in your blood. So that's what thrombocytopenia is. It means a reduction of your platelet count. And then also the risk of blood clots. And the most common place that people are seeing blood clots is in the brain, something called synovenous thrombosis. There are other blood clots in other parts of the body, but obviously the brain one is one of the more concerning ones in terms of risk of mortality. However, I think it's important to point out that we also are very well aware, and have been for quite a few months now, that getting COVID-19 is associated with life-threatening blood clots as well. This is a systematic review of the literature looking at the risk of blood clots. And essentially what I've found is that the risk of any blood clot is around 21% when you get COVID-19. And the risk of dying with a blood clot is, so people who get a blood clot, the risk of dying is about 25% compared to 15% for people who do not get a blood clot. So your risk of dying is about 1.74 times higher if you get a blood clot for COVID-19. So we're kind of talking about balances of risk here, right? You're talking about COVID-19 is fatal, and certainly you can get a blood clot due to COVID-19. However, the adenovirus vaccines, AstraZeneca and Johnson & Johnson, may be associated with a risk of blood clot as well. So we now have to start thinking about what's the risk benefit and what's your actual risk if you get these vaccines. And this is a nice visualization or sort of risk assessment chart from this Winton Center for Risk and Evidence Communication from the UK. And it's based on UK incidence and prevalence numbers of COVID-19, but I think it still holds true in Canada. In Canada, the risk of getting a blood clot, of having this VIT, this vaccine-induced thrombocytopenia, seems to be about 1 in 250,000 so far. So one person in 250,000 who have gotten the AstraZeneca vaccine will have this VIT syndrome and a resulting blood clot. So that translates to a risk of about 4 in a million in the UK in people 55 and over, and 11 in a million in people who are 25 and over. Compare that to your risk of dying if you get coronavirus. It's very much lower, especially in the older age group. The risk of dying in an accident or injury is about 10 times higher if you're 25. And the risk of dying in a road accident, obviously in a car accident, something that risk we assume every single day by driving around, that risk is very much higher than the risk of getting VIT from the COVID vaccines. Risk of getting hit by lightning, for example, is about 1 in a million. So if you're 55 and over, it's very similar to your risk of getting hit by lightning. I think an even nicer visualization is this is sort of the numbers that was used by the UK to decide that they would not use the AstraZeneca vaccine in people under 30 years old. And what they're doing is they're balancing the risk of having a blood clot from the AstraZeneca vaccine with the risk of you catching COVID-19 and being admitted to ICU for COVID-19 by age group. And you can see that very clearly in anybody 30 and up, the risk of getting admitted to an ICU and potentially dying is much higher than the risk of developing blood clots from the AstraZeneca vaccine. I want to point out, though, that this was the risk in the UK based on March numbers. And that's pretty important because we know that the UK, the incidence and prevalence of COVID-19 has dropped significantly since their peak in February. And in Canada, it's rising in its third wave. So we really have to look at the risk, the incidence of COVID-19 in Canada right now being very similar to the incidence, what it was at the end of February in the UK. So we can't really use March numbers for the UK. So let's look at February numbers. And these are the numbers for February. And what you can see is very clearly when your incidence of COVID-19 is 6 per 10,000, and in Canada, at least in Ontario, I think now it's about 3.5 per 10,000 per day. Your benefit of getting the AstraZeneca vaccine far outweighs your risk of getting a clot from the AstraZeneca vaccine. And that's really important to understand that in the end, even for people 20 and up, most likely, it is a safer to get the vaccine than to risk getting COVID and being admitted to the ICU and potentially dying. And Ben Chan, I think I mentioned some of his work last month, and he's updated some of this work. He's an assistant professor at U of T and a global health researcher, epidemiologist. And he posted these numbers for Ontario. They are Ontario and Toronto specific, but you can imagine how they extrapolate to your province. Based on the April 12th incidence of COVID-19 in Ontario, there was around 4,400 new cases. Now we're about, I believe, 36 or 3,700 today, and 1,300 cases in Toronto. So when he looked at age group 55 and up for the AstraZeneca vaccine, he calculated your risk of dying if you got COVID-19, then your risk of catching COVID-19 based on these numbers here, and your overall chance per day of both catching and dying from COVID-19. So these are the numbers by age in Toronto and all of Ontario. And based on that and the incidence of 1 in 250,000 of getting a clot from AstraZeneca, he calculated how many days of waiting for a vaccine before your risk of dying from COVID-19 outweighs your risk of getting a clot from the AstraZeneca vaccine. And essentially it's around 2 to 3 days. So if you delay getting a vaccine for 2 to 3 days, your risk of catching and dying from COVID-19 outweighs your risk of getting a clot from the AstraZeneca vaccine. So very clearly, and if you're over 65, that goes down to about 1 day. So very clearly, you should be getting the AstraZeneca vaccine, if that's what's available to you, as soon as possible, because the benefits far outweigh the risks. And that's really what we have recommended on our website for vaccines for people with IBD. You can go to the website to get this nice handout PDF, which was recently made available a few weeks ago, really for everybody to summarize all of the information. And you can see here, these are our recommendations for people with IBD regarding the COVID-19 vaccine that essentially discuss with your physician, because there still is limited evidence about the safety and effectiveness of the vaccines in people with IBD, although you'll hear from Dr. Lees very shortly that evidence is growing. It is recommended that you book your vaccine as soon as it's available. And if you are in a group that has eligibility for the vaccine, you shouldn't be removed from eligibility just because you have IBD or because you're on an immunosuppressing or biologic medication. And which vaccine is recommended? We are still saying that the best vaccine recommended for you is the first vaccine that you are eligible. As we saw from Dr. Chan's numbers before, do not delay in the hopes of getting an mRNA vaccine at this stage, especially if you're 30 years and up. It is well worthwhile to get the AstraZeneca and Johnson & Johnson vaccine if it becomes available to you. What has changed somewhat is this recommendation, or at least our advice and our advocacy, that people should be getting the vaccine in the manufacturer's guidelines, which for Pfizer is 3 weeks apart. The second dose is 3 weeks from the first, and for the Moderna and AstraZeneca is 4 weeks apart. And we're going to talk a little bit about this. Dr. Lees is going to review some of the science that has come out in the last 2 months as to why we are recommending that people with IBD have timely access on label 3 to 4 weeks apart from the first dose. And this is really advocacy at this stage. Unfortunately, the ministries of health have not acted on this. And most people are still being forced to wait 4 months, even if you're on a biologic or immune suppressing medication. So it's really, and we'll talk about what you can do about that, but essentially right now it's phoning your MPP, talking, emailing your Minister of Health, raising awareness on Twitter and other places where policymakers are reading stuff about the vaccine, and trying to advocate for yourself and for IBD patients. But for now, that's not something that patients or even family doctors have a choice in the matter. So with that, let's talk a little bit about the science as to why we are making that recommendation. And Dr. Lees is going to be our first speaker. I'm going to introduce both Dr. Lees and Dr. Pham-Huy. Dr. Lees, Charlie Lees, is a professor of gastroenterology at the University of Edinburgh, a UK Research and Innovation Future Leaders Fellow, and a consultant gastroenterologist in the Edinburgh IBD unit. His clinical and teaching and research interests have all been focused on IBD since about 2003. He was awarded a PhD in genetics of IBD and the prestigious United European Gastroenterology Research Star Award in gastroenterology in 2009. After spending 10 years working as a full-time consultant gastroenterologist, leading an incredibly busy and complex IBD clinic in 2019, he was awarded a very prestigious fellowship to allow him to pursue an academic career and do more research, and also talk to more patients through things like his YouTube channel, which I strongly recommend. If you go to YouTube and just search for Charlie Lees, he does an excellent job at reviewing some of the science in IBD and also COVID-19 and IBD, and make it in a way that's completely understandable for everybody. Charlie's leading the UK IBD COVID-19 working group and is senior author of the group's guidance published in Gut on how to treat patients with COVID-19. And then Dr. Ann Famhui is a colleague of mine from CHEO and University of Ottawa. She completed her medical degree at the University of Ottawa in 2003 and her subspecialty training in pediatric infectious diseases at McGill University in 2008. She also pursued additional training in clinical immunology. She's been at CHEO as staff since 2009, and she's the lead physician for the primary immunodeficiency clinic at CHEO. Her research interests include the diagnosis and management of primary immunodeficiencies, infections in the immunocompromised host, and immunization in special populations. She's program director for the Pediatric Infectious Disease Training Program, and she's also the current chair of Immunize Canada, a not-for-profit coalition of organizations with a specific interest in promoting the understanding and use of vaccines. I should also mention Dr. Pham-Huy was a member of our steering committee for the Canadian Association of Gastroenterology Clinical Practice Guidelines on Immunizations, and she has a particular interest in the effect of biologics in pregnant and breastfeeding women on the infants of those women and immunizations in that context. So she has a very close relationship with IBDologists in Ottawa and nationally as well. So welcome to you both. And we will start with a question from Dr. Kaplan to Dr. Lees.
Yeah, and first, Dr. Lees, thank you so much for talking to us from Scotland, where I believe it is 11:30 at night. So we appreciate you staying up to educate us. And just for the audience, I've known Charlie for many years. And before the pandemic, we used to travel and do seminars and conferences. And he is one of the most exciting, most dynamic speakers, not just to clinicians and academics, but to everyone that he speaks to. So it's really exciting for him to be able to talk to us on our webinar series for the first time. And I really want to ask you probably one of the most challenging questions I've asked anyone on any panelist to date, which is, do these COVID vaccines work in people with inflammatory bowel disease? Oh, and Charlie, you're just on mute right now. So
perfect. Well, thanks, Gil, and thanks, Eric, and thanks everyone at the Foundation in Canada for inviting me to come and talk to you tonight. Yes, it's late, but this is an important topic, so I want to share with you our experiences and our learnings from the UK's pandemic, specifically to IBD, and specifically to this question that Gil has asked: will my COVID vaccine work if I have IBD and if I am on immune suppressant medications?
Excuse me, Charlie, sorry to interrupt. You are on presenter mode, and we see your presenter view, not the full slide. If you can swap your display.
Thank you. How's that?
There you go. Perfect. That looks great.
Awesome. Great. The peril of dual screens. Right. So, spoiler alert. The answer is yes. But there are a couple of important caveats which I will come to. So if you bear with me, I'm going to work through this. So here are my disclosures. So I'm going to present to you a case vignette, a 45-year-old man. He works as a teacher. He's had ileocolonic Crohn's disease for 2 years, and he's on combination therapy with azathioprine and infliximab. His disease is well controlled. He has high blood pressure. He's a little bit overweight, but otherwise he is well. He may well have had COVID in March 2020, but didn't have a proven positive PCR test. At that point, testing was very limited. He comes with a number of questions. He wants to know if he's at greater risk of getting the virus or getting severe disease, and he wants to know what he should do about his medications. And importantly for today, he wants to know, should I have the vaccine? Which one? Will the vaccine work as well? And that's the critical question today. And what's the risk of reinfection? So we're going to cut straight to the should I have the vaccine question. And the answer is absolutely yes. Which vaccine should I have? Well, Eric has touched on this already, and I'll briefly go over this a bit again. But yes, he should have the vaccine because the vaccines have proven efficacy and safety in the phase 3 clinical studies and now in a vast amount of real-world evidence, and they all prevent severe COVID and death. So we have guidance to help back up this recommendation now. We have guidance from the International Organization of IBD, which very simply states patients with IBD should get vaccinated against COVID. The best time to do so is at the earliest opportunity, and vaccination should not be deferred because a patient is on immunosuppressants. And importantly, you should not defer or delay immunosuppressants for a patient to get vaccinated. In the UK, with the BSG and Crohn's and Colitis UK, we published similar guidance stating strong support for COVID vaccination for patients with IBD, stating that the risk of COVID vaccination in patients with IBD anticipated to be very low, and indeed that is what has transpired. And in patients taking immunosuppressive drugs, the key concern relates to the theoretical risk of suboptimal vaccine responses. And that's going to be the meat of my talk when we get to it in a minute. So, which vaccine? This is simple. Whichever one you're offered, they all work well. And we believe they all work well in IBD, as I will show you. So that is either Pfizer-BioNTech or the Moderna mRNA vaccines, or for us in the UK, Oxford-AstraZeneca, as the 3 vaccines that we currently have available and licensed. Add to that Janssen, as Eric has said. Now, importantly, in the UK, we had a very rapid initial rollout of vaccination starting in December 2020. But at the end of that month, the JCVI, which is our long-standing Joint Committee on Vaccination and Immunizations, which is not a political body, but it's a very reputable community of scientists and clinicians, recommended that delivery of the first dose should be prioritized to as many individuals as possible. And so they stipulated this recommendation that was then followed, that the second dose would be delayed by up to 10 to 12 weeks. I'm not going to go to this into any great detail today, but to give you a little bit more flesh to what's happened in the UK, we had the first 4 priority groups that had a first dose of vaccine by mid-February. And importantly for us, that included the clinically extremely vulnerable people. That in the UK equated to the people who underwent shielding, and that included our higher risk IBD patients on therapy. It didn't necessarily include all patients on biologics. Patients who were well on biologics, and that could include a patient who was on combination therapy, just like our man here, would be in group 6. And so by the middle of April, for these groups 1 to 9 had all received a first shot of vaccine. So this is where we are at currently, with somewhere in the region of, so here are 34 million people having had the first dose of a vaccine in total, with 14 million people having had 2 doses. Now you can see the split here by the 4 nations. And you can see really clearly here, I believe, the impact of this split dosing. So this is second doses. And bearing in mind, the first person had their vaccine on the 8th of December in 2020, you can see that the second doses really don't kick in until much later on. And if you go back and look at that graph of the pandemic that Eric showed you, showing you when the UK wave dropped down in the last 2 to 3 months, actually the vast majority of that improvement has been down to a 110-day lockdown that allowed the transmission that Gil was showing you earlier on to be broken, those chains of transmission to be broken, with an added impact of vaccination, of course, but the meat of that was from the lockdown that was taking place. So let's get on to the important question here that Gil's asked me. Will the vaccine work as well? Why are we even asking this question? Well, we're asking this question because we have seen in IBD, in patients who take immune suppressants and anti-TNFs alone or in combination, that immune responses to certain vaccines, and that includes pneumococcus, it includes hepatitis B, and it includes some other experimental vaccines, is reduced compared to the background population. So the question was, would this be the same for people getting COVID vaccination in this situation? So the data I'm presenting today are from a pan-UK study that was the brainchild of Tariq Ahmed in Exeter, Nick Powell at Imperial in London, along with Nick Kennedy, who trained with us in Edinburgh, who then is now working with Tariq in Exeter, and Claire Bouchy, who is the most extraordinary trial manager on the planet, who had COVID herself and has struggled with long COVID symptoms, and despite all of that, set up the most fantastic study. And what Claire did was set up these 92 sites that recruited an astounding number of patients, as I'll show you on the next slide, in the 12 weeks leading up to Christmas 2020. This is Loran and Kate, my clinical fellow and research nurse, that catapulted us to third place in this league table, something that we're very proud of locally. So this is what we did. We recruited patients with IBD on infliximab primarily, because these are the people we were interested in exploring to see whether or not infliximab as an anti-TNF agent had an impact on the immune response to SARS-CoV-2 infection and also to vaccination. And we thought, why not use vedolizumab as a good control? Because vedolizumab is gut specific. It's not been shown in other situations to have an impact on vaccine and other general immune responses. And because patients come at regular scheduled intervals to the infusion suite to have their doses, usually at 8 weekly, sometimes accelerated, then it would provide a very good control. So we recruited 2 patients on infliximab for every 1 on vedolizumab, and you can see this was done to a total of 7,229 patients up until Christmas 2020. Now, comparing these 2 groups together, we first had to ask a question, which was, did the patients on infliximab and vedolizumab have similar COVID experiences? Did they adhere to social distancing measures in the first big wave in the same way? And the answer was they did. And was their exposure to COVID-19 cases the same? And the answer was yes. Most importantly, there were no differences between infliximab and vedolizumab treated patients who reported symptoms of suspected COVID-19, who tested positive by PCR for SARS-CoV-2, or were hospitalized with confirmed COVID-19. There was a difference geographically if we looked. So you could see actually in Scotland, we had a relatively lower level at this point. This was an inclusion into the study, okay? So this was before our next big wave. This was September, October, November, December when people were recruited. This was testing the antibodies against SARS-CoV-2. So in Scotland, in the southwest, in Wales, the rates were about 2%, and the hotspots that we'd seen in London and the northwest and the Midlands. So patients on infliximab and vedolizumab had the same experience. They had the same number of suspected and confirmed infections, PCR proven against SARS-CoV-2. But when you measured the antibody levels against the virus, against the nuclear part of the virus, you saw interesting results. So patients on infliximab, only 3.4% of them had antibodies against SARS-CoV-2, whereas it was 6% in patients on vedolizumab. So that was a very big difference. And moreover, when you looked at the impact of also being on an immune modulator, and that means azathioprine or mercaptopurine or methotrexate, that there was an even more marked effect. So if you were on infliximab and an immune modulator, you had antibodies at 3%, whereas if you were on vedolizumab without an immunomodulator, it was all the way up at 6.5%, 6.3%. Okay, so that's the first important bit. The second bit then is to understand which of the factors of the many that we looked at were associated with having antibodies to COVID. And so we looked at a number of important things here. What we saw was that, as was expected and as has been widely documented now, being of non-white ethnicity was strongly associated with having antibodies to COVID, as was the geographical variation that I've shown you already on that previous map. And interestingly, when we asked people how well they adhered to social distancing measures, those who did not adhere closely to social distancing measures had higher level of antibodies. What factors are associated with not having antibodies to COVID? Well, being on infliximab versus vedolizumab and being on an immune modulator were the two key factors there. So that's one way of looking at it. The next way to ask it is that if you have had a proven infection of COVID-19 with SARS-CoV-2, how likely are you to have antibodies to COVID, or how likely are you to have seroconverted? And when you have patients on vedolizumab, you are 83% likely to have seroconverted, whereas in infliximab, if you looked at all comers, it was 48%. If you looked at combo patients on infliximab and an immune modulator, it was 37%. So in this phase, we said, if you're on infliximab, you're no more likely to get COVID. That's good news. After COVID infection, you have reduced antibodies. And we said to patients, please keep taking your medicines. I want just to add at this point, which is that from all the data that we have seen, and we've just completed a very big experiment in the Open Safety dataset looking across all patients in the UK with immune-mediated diseases, so including skin and joint disease, we see no impact of anti-TNFs on severe COVID outcomes. So you may be worried that you have disadvantaged here because you may be taking infliximab or adalimumab or immune modulator, but the answer doesn't appear to be that. The answer seems to be that you may still get COVID, but you're not as likely to get severe COVID, and your antibody levels are less. So the important thing then, how does that translate to COVID vaccination? So this is the meat. This is the second major output from the Clarity IBD study that's been kicking about for about 6 weeks now as a preprint, as is very common for us to do these days. But the full publication came onto the Gut website in the last week, that's now fully published and free access to see. So first question here, what is the impact of infliximab on the immune response to COVID-19 vaccination? It's important to recognize here that we're measuring a different antibody here. We're measuring the anti-SARS-CoV-2 spike antibody. So this is different from the anti-nuclear capsid antibody that tells you if you've had a naturally occurring SARS-CoV-2 infection. This is looking specifically at vaccination. In this data cut, we looked at 865 patients on infliximab, 428 on vedolizumab. Roughly half each had Pfizer-BioNTech, and roughly half each had the Oxford-AstraZeneca vaccine. So this is the most important result, and this is after one dose of vaccine. So if you've had one dose of vaccine and not had previous infection, this is what you see. And you see that patients on infliximab on the left here with Pfizer-BioNTech, and patients on infliximab on the left here in green again on the Oxford-AstraZeneca, have lower levels. This black line is the average or the median here, have lower levels than patients who are on vedolizumab, with both vaccines. So if you're on vedolizumab with the Pfizer-BioNTech, you see the black line here. It's in a good range, and here on the right with Oxford AstraZeneca 2. But if you're on infliximab, it is lower. Okay. This blue line indicates the cutoff on this assay that confers protection in the tests that have been done. So if we try to understand what factors are associated with spike antibody concentration, and it's the same for both of the vaccines, so this just shows for all of them, you can see infliximab compared to vedolizumab being on an immune modulator, a subtle effect for Crohn's disease, an effect of being older, an effect of being a smoker, and actually if you're of non-white ethnicity, your protection was rather better. What percentage of patients develop protective antibodies against COVID? So this is similar to where we did it with natural infection. We looked first at the rates, and then we looked at how many had seroconverted. So this is the percentage that are seropositive for the vaccination. And I'll just show you the left-hand set of panels here. This is for the Pfizer-BioNTech vaccine. Excuse me. And you can see that patients on infliximab and azathioprine or another immune modulator, 27.1%. It gets a bit better if you're on infliximab monotherapy. Vedolizumab with an immune modulator here, 55.6%. Vedolizumab monotherapy was the best out of all of them. And this was reflected in what we see with the Oxford AstraZeneca vaccine. Now, so far you might be thinking this doesn't look great, but actually there is a really important good news element to this story. And the important part to this is that if you've had 2 exposures to COVID antigen, that means if you've either had previous infection with COVID and 1 dose of vaccine, or if you've had 2 doses of vaccine, your protection is then complete and very good. So I want you to focus on this left hand of these 4 panels first. And you've got these 3 green lines, which are for the infliximab group. And you can see this is what we saw before, 1 dose with no prior infection, you're below this blue line. But if you've had 1 dose from prior infection, you're well above it, as you are if you've had 2 doses. And we see the same for, in this green, in the next panel across here for vedolizumab, but everything starts a bit higher. And then importantly, we also see the same positive effect of the vaccine with the Oxford AstraZeneca. So here's the 3rd panel along here, the second one in the green. You can see 1 dose, no prior infection. It's the same as what we saw with the Pfizer-BioNTech, but 1 dose with prior infection, you're much higher. And we now have data to support with 2 doses of Oxford AstraZeneca that shows the same effect. So patients on infliximab after 1 dose of either vaccine have lower levels of protection with antibodies to COVID, but, and importantly, patients on infliximab have normal levels of protective antibodies if they've already had COVID and get 1 dose of vaccine, or if they've had 2 doses of vaccine. What medicines are affected? Well, we suspect this applies to all anti-TNF drugs. So for us, that means infliximab and adalimumab. And whilst we did not study it separately, we suspect there is also an effect here with patients who only take immune modulators. So if you're on azathioprine, mercaptopurine, or methotrexate as monotherapy by itself, there may also be a small effect after 1 dose. And we also suspect this also applies to people taking these medicines for non-IBD indications like inflammatory joint or skin disease. But again, we can't say for certain because we didn't study that specifically. I think this is the most important slide I want to show you tonight. I'm taking 1 of these medicines. What should I do? My most important message to you is not to be worried. Please keep taking your medicines, get vaccinated at the earliest possible opportunity, and I strongly believe you should take whatever vaccine that you're offered, that they all show a very good effect with a very low risk. After 1 vaccine dose, everyone in society should continue to socially distance. I believe that, but I think that's particularly true for patients who are on 1 of these medicines. And as Gil and Eric have said, we would try to get priority for the 2nd vaccine dose. So, key take-home messages overall, I think, are Partly it's to do with risks, we've discussed. It's not really to do with IBD. It's much more to do with age, comorbidity, and maybe active disease. So that's important. So it means keep taking your medicines. Continue and proactively to treat and be treated for your IBD and encourage adherence. So don't stop taking your medicines because you don't want to have a flare-up now. Get vaccinated, either vaccine, even if previously infected with a virus. Make sure you get both shots. No matter how delayed it is, make sure you get both shots and continue to follow public health rules. We then have this question of how we vaccinate the world. I think that may be something for Q&A more than for now. So I just leave you, I think, with a couple of points that I want to just bring across. This has been a very challenging period for all of us. It continues to be so. We have had a terrible pandemic here in the UK. My experience is that it affects people in all different kinds of ways. It affects different people from different facts of society in different ways. And it includes patients and staff, friends and family. So be kind and considerate and look to build resilience in yourself, others and your teams. We still don't really know what comes next, but actually overall, what we are seeing in the UK is that what happens next through lockdown and then from vaccination, actually I think looks very optimistic now, finally. There remains no particular signals of harm for patients with immune-mediated diseases, including inflammatory bowel disease or immune-suppressant medications. So please take some reassurance from that. And the reasons to be optimistic. So that's it from me. And I'll hand back to my chair people for the next bit. Thank you for listening.
Thank you very much, Dr. Lees, and I particularly appreciated your quoting Seneca. The need for stoicism in this time is huge. With that, I want to introduce Dr. Pham-Huy, who, as I mentioned, is a colleague of mine and pediatric infectious disease expert. And sort of the question that I presented to her, knowing the data from Dr. Lees and the Clarity IBD group, was, is this the full story? And you know, we don't want to confuse you with too much immunology, but I think it's really important that we, you know, present more of a story when it comes to vaccines and immunology, because, you know, I think the message that we've gotten is that antibodies aren't necessarily the full story. So Dr. Pham-Huy, if you can share your screen.
Yeah. Are you seeing my screen and can you hear me?
Yes, we can hear you and we can see your screen. It looks perfect.
Excellent. First, I want to really thank the whole group for inviting me. I think these webinars are so fantastic for your healthcare providers and your population. It's so clear. There's so much clarity, I think. So really appreciate being able to speak today. Although I will give you a bit of the story. I'm not sure I'm going to be able to give you the whole story as the story continues to unfold. Whoops. So I don't have any disclosures, but I do have a disclaimer that I put on for every talk I give on COVID, which is to remind people of today's date. So we are April 29th, 2021, in case by May 1st, everything I say has evolved. Again, the information that I'll review today is based on current knowledge and evidence. And as we have all learned as a global community, science evolves, it changes, adapts, it changes its mind, it reverts again. It's mind-boggling, and so it's never boring. So I'd like to start by reminding everyone that we're actually facing two enemies or in this global pandemic. So our first one is very familiar. You know, I think you show this image to a 2-year-old, they would probably recognize it. So SARS-CoV-2, but we are also facing another enemy, which is this is the unknown. And there's still a lot to learn about this infection, this disease, this virus. We have learned tremendously if you think back at where we were 15, 16 months ago, but there's still a lot to learn. And it has been a very humbling experience, you know, to learn about this infection and trying to plan and trying to, you know, predict the next step. So same thing when we're dealing with COVID-19 vaccines. There are so many different moving parts to it. I have the privilege to sit on a variety of COVID-19 vaccine working group or committees. and the number of issues that we want to address, the list is just growing every day. And all of these are important, all of these are relevant, and also of a varying degrees depending on the population, but they do need to be addressed, and we hopefully are trying to address this with evidence and science. So again, COVID-19 vaccines, again, my little black cloud. I want to remind everyone that we actually don't know the correlates of protection. So the word correlates of protection means that, is there a marker or a surrogate or something that we can measure that will tell us that we are able to prevent infection? So for some diseases, like diphtheria or tetanus or hepatitis B, we have actually a number, like an actual quantity of antibodies, for example, in their blood, that we know that if we have that level, then we are protected from disease. So in the case of COVID-19, we actually don't know yet the correlates of protection. And another unknown is we're starting to learn about protection, immunity, but we actually don't know the duration of protection. We are extrapolating from different viruses, and we do have, I guess, real life experience for about 15, 16 months, but no one has 5-year or 10-year experience with this virus, so we can't tell you that yet. The other thing when we're dealing with COVID-19 vaccine is there's a lot of talk about vaccine efficacy and vaccine effectiveness. And again, we're trying to figure out the degree of protection from the vaccine. But I like to remind people again, it's depending on what we are measuring. Things that were measured or looked at specifically in clinical trials may be different from what the broader population or the patient or the healthcare provider is looking at. So for example, in most of the studies, actually they're not in order, but most of the clinical trials looked at vaccine efficacy being the degree of protection against symptomatic disease. So they would have documented infection, confirmed infection, so PCR positive, with a set of predetermined symptoms, whether it's fever, difficulty breathing, etc. But some of these studies also looked at severe disease and death and prevention of hospitalization, but there may have not been enough cases to really attribute. In general, there are some trends to suggest that definitely these vaccines are actually quite efficacious to prevent severe disease and death and prevent hospitalization. But what about preventing asymptomatic infection? As we've heard, there are some patients, there are some individuals that really have no symptom, but in fact are infected. And then what does it mean in terms of preventing transmission? And I say that because we are talking a lot about, what does it mean if I have one dose of the vaccine? Can I go see my unvaccinated or immunocompromised household member or friend? So in terms of preventing transmission, it's still an unknown. The ideal COVID-19 vaccine ideally would elicit long-lasting, high-titer neutralizing antibody. I've said the word titers twice, so it's really important. High antibody titers. And we'll talk a little bit about what that means, high neutralizing antibody titers. And as well, in an ideal world, would provide what we call sterilizing immunity to prevent disease and onward transmission. So ideally we want, and there are some vaccines that definitely can do that. They can prevent disease, but also decrease carrier status and therefore decreasing transmission. And I didn't put it in, but the next step would be, the next criteria would be a safe vaccine. So we'll talk a little bit about immunity to SARS-CoV-2. We're definitely gaining more experience. I'll tell you that the immune system is the system that I have the most respect for. I think I'm a bit biased. It's my favorite system, but it is very complicated. It's complex. There's multiple aspects to it. There's a lot of redundancy. There's a lot of coordination between different pathways or parts of it. But I like to simplify things. I like to put things in boxes. So I'll give you 2 big boxes today. So first, immunity to SARS-CoV-2, I'll tell you there's 2 big things. First is your innate immunity. So you may have heard this term used. Innate immunity entails to a system, a program that everyone is born with it. It includes a variety of barriers. It could be physical barrier, like your skin, your epithelium. It could be chemical, so it could be, even the acidity in your stomach. And it also involves a variety of different, very important cells. They're what I would call the first responders. So at the first sight of danger, they arrive very fast. It gets triggered very quickly within minutes or hours. Unfortunately, it doesn't have memory. So it's fairly specific. So it shouldn't be triggered by anything. It should be triggered by a true danger signal. But the response will be kind of the same with each presentation. It doesn't remember, fine-tune it for the next event. So that's innate immunity, which is very, very important, and very important in the context of SARS-CoV-2. We've had some lots of reports and studies documented individuals who have fulminant severe SARS-CoV-2 that was not expected to be so severe. And in fact, when we dig deep, they have some genetic defect that implies some of their innate immune pathways. So the other big important arm of immune responses to SARS-CoV-2, but also other pathogen, is your adaptive immunity. So that's your learned program. This is, you get adaptive immunity from lived experience, either through a natural infection or active immunization. And this category entails antibodies, which we've heard all about. So we like antibodies. So antibodies are very important in adaptive immunity, but it also involves a variety of other specialized cells. It takes a little bit longer to activate your adaptive immunity. And so it usually takes, we usually say, 7 to 14 days, or a couple of days. And definitely it actually continues to evolve and fine-tune itself within weeks and even months. This key feature of adaptive immunity is memory. And so memory, once a pathogen, so SARS-CoV-2 is presented to the immune system, the adaptive immune response will remember specifically that viral infection and be prepared for the next encounter. So it is a very specific immune response. So innate adaptive, sometimes I compare this to innate being your fire smoke signal sprinklers. So it will sense danger, so the smoke, and then activate very quickly. It's very effective. Sometimes it's a bit messy. Adaptive, those are your firefighters that come in. They don't come instantaneously, but they are quite effective and they're targeted. So that's innate and adaptive immunity in a nutshell. So we'll just put innate immunity aside. We'll concentrate on adaptive immunity to SARS-CoV-2. And we already talked about a very important part of adaptive immunity, which are your antibodies. And we'll talk a little bit more. There's many different types of antibodies. They're in subtypes. They change over time. But I'd like to introduce you to 3 other sometimes forgotten members of immune memory or immunity. These are your memory B cells. And in fact, memory B cells are produced at the first encounter with the infection or the vaccine or the antigen. B cells actually are the types of cells that make antibodies. And so you want to keep some memory B cells so they can make a lot of antibodies at another, as a second encounter. So they're like the antibody factory. Then we have CD8 T cells. So these are a type of cell, these T cells, that can actually kill directly. So viruses, what they do is that they infect our host cells or human cells. And so they hide inside the cells. But these CD8 T cells are able to recognize them and actually kill them directly. So these are very cool cells. And then we have our CD4 T cells, another subset of T cells, which role is actually to help the B cells make the antibodies. So they're called T helper cells. And there are a memory component of both of these T cells as well. So again, this is your A team. This is the team you want on your side to help you with adaptive immunity to SARS-CoV-2. This is a bit of a schematic on what happened, just to show you the relationship between innate and adaptive immunity. So innate starts first, then we have adaptive immunity, and then we have viruses that go up. And then again, with hopefully good, effective adaptive immunity comprised of both your antibodies and your T cells, you will get those viruses out of your system and get rid of them, and the viral load goes down. This is just to see what happens if you get re-exposed. So this in general, again, on this axis, we have the concentration of antibody over time. And so let's say you get your first exposure and your first infection to SARS-CoV-2, unfortunately. So as you see, it takes a little bit of time before you make the antibodies. There's a bit of a lag. And then you have what we call our primary immune response. So then the firefighters are coming in. At the beginning, although they're pretty good, they're new. So what we call low affinity antibodies. So they're effective, but they're not the most refined antibodies. But you will make memory subset of B cells, for example, that will remember. And if you are exposed a second time to that same pathogen, they will remember, and the immune response will be much stronger, more robust, more fast. You will be producing higher affinity antibodies, and this is what we call the secondary immune response. So not all antibodies are made equally. I won't go through all the details. There's many different subtypes, isotypes, but there's a concept of affinity and avidity that I alluded to. So affinity is really the strength of binding between an epitope. Epitope is the actual little binding part to, so this is your antibody. It looks like it looks like that. And then it has a binding site to your antigen, and epitope is just exactly the specific spot where it binds. And then avidity is the collective affinity of multiple binding sites. And so each antibody has 2 binding sites, but sometimes they can hang out together and they can bind a bunch of different epitopes and then increase that strength. So it's like teamwork. This is again another graph, a little bit more fancy, that shows you what happens over time. So this is again, let's say you get infected with your SARS-CoV-2, and so RNA is the viral load, the viral material, how much virus you have, and it increases over time. If we didn't have any adaptive immunity, this would just go out of control, and the virus would just continue to replicate. But because we have adaptive immunity, the first antibody that presents is in the form of IgM as well as IgA. So again, just to remember, there are different types of antibodies that presents initially, that these generally have a bit of a lower affinity, but they're quite avid. They can hang around together and then bind. And then just to show again, the IgG, so these are the more long-term high affinity antibodies that take a little bit longer to come into play, but they last much longer. They'll plateau and eventually will decrease. They put here, this is possible. So this was just an extrapolation, theoretical, is it 54 days, 76 days, over years? So there are some infection that we know that can have sustained IgG levels for quite some time, but some, I would say the majority of infection, actually, it actually goes down. It doesn't mean you're not protected, but it just means that you're not, sustaining the quantity of circulating antibodies. So the big question is that what happens if you actually, so maybe I'll take a step back. So when I showed you this graph here, we were talking about infection, but pretend that this is the same thing as your initial exposure is your first dose of vaccine, secondary exposure is your second dose of vaccine, and you would expect this primary response and after the first dose, and a very high secondary immune response with a second. So this is what we would expect with a lot of our vaccine, not all of them, but the majority of them. The first dose, the bang for your buck is in your first dose, but the second dose is that you want to make very robust, high affinity antibodies, high titers of neutralizing antibodies, but you also want that like longer sustained level. So this, I would say, I kind of just doodled it myself. So it's not up to scale and it's not exactly accurate, but it's just to illustrate a bit this concept. So let's say you're here, you get your first dose. I kind of wrote day 10 because it appears in a lot of the initial clinical trials, at least with the mRNA vaccine, that the placebo group, so the group that did not get any vaccine versus the group that got vaccinated, kind of like, separated around the 10 days. So we assume that you start to make antibodies around that time. And so you get this, primary response. And then let's say, and again, I think that it wouldn't dip that low, but let's say you plateau a bit and then you get your second dose of the vaccine, of your mRNA vaccine as per authorization, which is between 21 and 28 days. And then, wow, you get a nice secondary immune response with high titers of neutralizing antibodies. And then eventually, if you were to measure these antibodies over time, they would slowly wane, plateau, and eventually, be at fairly low levels. But what happens if you actually extended this second dose? So instead of giving it here, you decide to give it at 112 days or 120 days. This is the 4-month, and you delay. So eventually what happens is that the antibody that are produced after the first vaccine dose would kind of like plateau and then go down. But it doesn't, it's not necessarily zero. It's unlikely to be like a true zero. Sometimes in even natural infection, when people measure their antibody levels, they're undetectable. It's probably not a true zero, but not enough for us to be able to detect in our testing. But if you were to give the second dose here, the assumption is that you would still get the secondary immune response with after the second dose, you would get high neutralizing antibody titers again, because this is your second exposure again. From an immunological perspective, biologically, when people ask, do you think the first, if I delay so much, it won't work? I think it'll still work fine in terms of if you get the second dose delay. The only caveat is that there are studies that show that if you do have high titers of neutralizing antibodies, that may help with preventing infection. Although again, another caveat is we actually don't know what is that level that you need. Is it 3? Is it 6? Is it 9? Is it 10? We don't know. So the risk here is that, in fact, if you do need a higher level of neutralizing antibodies to prevent an infection, then this is your risk of exposure. It's that time between the doses. So again, I don't think that, again, based on clinical immunology, clinical vaccinology principles, that I don't think that delaying the second dose is going to harm the effectiveness of the vaccine. I think you'll still get your secondary immune response. But, if you had to compare both, right, like maybe both are fine in terms of the antibody titers, but in general, high levels of neutralizing antibodies are more effective at preventing infection. So you might be at risk within that period if you get a first dose and then you decide to not follow public health precautions and you get exposed to COVID-19, you might still be infected. But again, when you get infected, that infection will likely act as your secondary exposure to the antigen. And so you might have still a brisk immune response. You may not have severe disease, but you might, you'd still be infected. Again, I'm saying this is, you may based on all of these principles. So there are no studies that have specifically purposely designed it to be done this way. There are some real life effectiveness data on jurisdictions that have delayed the second dose and what happens. So that's just kind of principle. So I hope it kind of makes sense to you. So what we know so far there's some very good news, because people had to guess what the main antigen or the main thing to target on the SARS-CoV-2 virus was, and it was the spike protein. And in fact, that seems to be the right target. When we measure antibodies, neutralizing antibodies in patients that have had COVID-19 vaccine, we measure both their antibodies, but as well as their T-cell response. It appears to be very targeted towards that spike protein. So that's good news for vaccine manufacturers. The COVID-19 vaccine appears to elicit very high neutralizing antibodies after a 2-dose schedule, somewhat better than SARS-CoV-2 natural infection, at least over the short period of time during the time that we've measured them. So following vaccination, we also have production of S protein specific memory T cells and B cells that are developed. And that was also documented in the clinical trials. So that's good news, is that, we measured not just one part of immunity, we measured antibodies, we measured T cells, we measured memory B cells. And so together with the high affinity SARS-CoV-2 antibodies, this hopefully will likely help prevent subsequent infection with SARS-CoV-2. So what we think it means, again, I'm putting my black cloud because that's what we think it means, is that again, if we can elicit high enough neutralizing antibody titers, then maybe that'll be enough to kind of neutralize the virus, therefore blunt the size of the initial viral inoculum and avoid progression to severe disease. And hopefully, if we can prevent, that inoculum, there might still be symptomatic disease, but hopefully we can prevent, ideally symptomatic disease as well as infection and transmission. There's always going to be some virus that, get through the neutralizing antibody stage, but hopefully again, with the fact that we're eliciting memory T cells, then those cells also can help and have the time to control the infection. So like I mentioned, there's definitely tons of studies and also based on other pathogens or other infections that show that neutralizing antibodies do wane over time, that re-exposure or a secondary, presence of the antigen will likely stimulate memory B cells to mount a rapid and effective humoral response. Humoral is again a kind of an antibody response. Decreasing antibody titers do not necessarily mean that there is waning or defective immunity. And antibody titers are expected to decrease following resolution of an infection. That's what it does. Again, I think that antibodies are a big part of the story, but not the whole story. And I think for certain population, and maybe even for the people with mild disease, the main protective effect might be their T cell immunity. We have some patients who from a genetic immune deficiency don't have any B cells, so they cannot make any antibodies whatsoever. So there's definitely been reports of patients with this kind of condition, so a condition where you don't make antibodies at all, that then acquire COVID-19 and they do okay, which means that they didn't have any antibodies and they were able to clear their infection. So likely it's a team approach. I think antibodies are important, but they're not the only part of immunity that you need for protection against SARS-CoV-2. There is increasing studies of different groups that are looking at, again, various aspects of immunological memory. This group has probably done the more extensive in terms of looking at both antibodies, but memory B cells and memory T cell CD4 and CD8 up to 8 months after infection. And I found that the majority of patients, so they studied a cohort of 188 patients who had COVID-19 infection and then showed aspects of immune memory in that cohort. So again, remember that there's more to immune protection than just antibodies. So now just to end, this question I get asked a lot. So what do I do if I have not yet received any COVID-19 vaccine? What do I do if I've only received 1 dose of a 2-dose COVID-19 vaccine? And what do I do if I have actually received 2 doses of a 2-dose COVID-19 vaccine? And these are very important questions. And I think the answer actually changes depending on where you live and what is the date, because it is related to what's going on in the community and where are we at with in the global pandemic. So right now, again, as of April 29, 2021, and we're speaking at this point in Canada, we are experiencing a third wave in most areas in the country. Right now, the answer would be to continue to follow public health guidance. And again, the fact is that no vaccine or no measure is actually 100%. And therefore, if there's still some high number of circulating viruses in your community, there is a chance that you get infected or get exposed, and therefore having 1 or 2 doses of vaccine or no vaccine, obviously, doesn't make you completely invincible. There's still a chance, and we've seen like as much as 94-95% efficacy is amazing. It's not 100%. So if there's high enough numbers, there's still people that are going to have breakthrough infection, hopefully not severe infection. So that's that. So a few take-home messages. SARS-CoV-2 infection and immunization elicits an adaptive immune response, so that's excellent news. Protective immune responses include 4 major components. So your antibodies, your memory B cells, your memory CD4 T cells, and CD8 T cells. Infection and vaccine elicits high levels of anti-S, so anti-spike antibodies, which generally wane over time, but other mechanisms likely persist longer, memory B and T cells that are activated quickly with exposure. So if you are reinfected or you get the second dose of vaccine, with the goal of preventing infection and or at least diminishing disease severity. That's all I have.
Thank you very much, Ann. Appreciate that. That was great.
Yeah, both you, Ann, and Charlie, those presentations were amazing. We had a whole bunch of questions before this webinar, and we tried to integrate those questions and answering them into the questions we've asked you to present on. And during this webinar, we have had a huge number of questions posed by the audience. We apologize, we may not be able to get to everything, but what we're going to try to do is group them up and then try to answer them. Before I ask a question specifically of Ann or Charlie, I want to address one that was commonly asked before the webinar and is also being a recurrent theme in the Q&A, and that's all around advocacy for the IBD population. A lot of people are, understanding the data that Dr. Lee's presented around needing that second dose in a timely fashion. What can we do as CCC and what can you do as a member of the IBD community? And so to answer that question, I just wanted to give you a sense of just a little bit of a historical perspective. A year ago, we started the Crohn's and Colitis Canada's COVID IBD Task Force with the whole idea of getting experts, gastroenterologists represented every region across the nation, both pediatric and adult, including public health, infectious disease specialists, nurses, patient representatives, so that as issues evolve over time, we can review them and provide recommendations to Crohn's and Colitis Canada, who can then act as an advocacy arm. And so clearly, the vaccines has been a huge part of what we've been doing since the beginning of 2021, including understanding the data that was going to be coming out from UK. And once that data kind of came out, we reviewed it as a committee. We recommended as a committee that there shouldn't be a delay between first and second dose, particularly for IBD patients on biologics like infliximab, all based on the data that Dr. Lee's presented. Based on those recommendations, Crohn's and Colitis Canada sent a letter to NACI, which is the National Advisory Committee for Immunization, which provides guidance to the different Minister of Health provinces for each of the provinces across the country. And in addition to sending those letters, we also posted all this information on our website, educating you, the community, and CCC also reached out to the Minister of Health offices for each of the provinces. And so that's kind of, a huge effort in us in trying to create advocacy, because our goal is to try to get all patients with IBD vaccinated and to get their vaccines as timely as possible. One of the things that Charlie said in his presentation in reflection of what's happened in the UK, the UK and likewise in Canada have kind of favored getting most Canadians the first vaccine before most Canadians get the second dose of the vaccine. And that's extremely a difficult decision around vaccine timing. And it's up to groups like Crohn's and Colitis Canada that know the IBD population the best to advocate where kind of guidance is kind of becoming a bit diffuse from what we think is the right thing to do. So we're doing everything in our power to reflect that. And in addition to that, there are individuals that are reaching out to provinces, even outside of CCC. I can tell you myself, my colleagues have reached out to Alberta Health Services and the groups that are driving AHS to try to get patients on biologics onto that second dose. So these are things that we're actively doing. And again, in the context of what you can be doing in the IBD community is also, sharing your information with CCC, sharing your information with the Minister of Health's offices in the different provinces, and just recognizing that an individual family doctor, individual gastroenterologist, or an organization like CCC in and of themselves doesn't have the power to affect that type of change. But we will advocate for you 100%.
Agreed, Gil, and I think we have to acknowledge that both NACI and the provincial advisory groups really are balancing many different factors, and they're trying to do the best they can for as many people as they can. Hearing through the grapevine, they are aware of the Clarity IBD study from the UK, and are trying to do their best. So I think we really have to continue our advocacy work. But in the meantime, the reality for the IBD patients is that they just don't have a choice. They should get their first shot. They will be booked for their second shot, likely 16 weeks after their first shot. And we know from the Clarity IBD study that the second shot is effective, even when it's delayed. And so it's important just to get that first shot and protect yourself between the first and second shot. Stay isolated, stay home, especially if you have active disease or you're on steroids, and do your best to follow public health guidance. So we're going to try to address some questions. There were a lot, I'd say well over 100. So we're not going to be able to get there. We're not going to make Dr. Lee stay until 4 o'clock in the morning UK time. I'm going to start with maybe a group of questions, special population questions, let's call them, for Dr. Pham-Huy. The first question that we keep getting is, if you get, let's say the Pfizer or Moderna vaccine as shot number 1, can you get the AstraZeneca or Johnson & Johnson vaccine as shot number 2, or vice versa? Can you mix and match the shots?
Yeah, that's a good question, especially in the context of, uncertain vaccine supply. But at this point, I mean, we'd have to go with evidence. And at this point in time, there's not good studies to show what it would look like to mix and match the vaccines. Now, all of the vaccines contain like their main antigen, or what they're targeting is the spike protein. So that's similar, but they have different platforms, and some are RNA, some is DNA, and so it's not recommended. Although I know that there are some jurisdictions that are exploring that option. So I would say stay tuned. The official line right now is not to mix and match, and just to stick with the same vaccine that you've received, but that might change as we get more information in the coming weeks.
And I'm aware, I don't know if Dr. Lee has anything to add, but I'm aware of a study in the UK that is looking at that very question. So we should have that answer soon. Are you aware of that, Charlie?
Yeah. They're looking at this because actually I think that the UK are planning to give everyone an mRNA booster shot, certainly the at-risk groups, which will include the IBD populations, in the autumn, and that will be Pfizer. So they're doing the studies now to look from that reason, really, rather than for the second dose of the standard immunization.
That's great.
And actually, that's a great segue into a question for Ann in terms of the immunology. Do you think that we're going to be needing booster shots down the road, and where do you see that kind of evolving down in the future?
Another good question. So we don't know yet. What I suspect is that depending on what types of variants of concern will be emerging and circulating, it might actually be more of a fine-tuning the vaccine to address the circulating variants, as opposed to a true booster. And again, it also will depend on what situation we're at, right? Like if we're still in, like, God, I don't want to even say wave 5 or 6, and in a year, then the stakes are high. You're going to want to have those high neutralizing antibodies circulating in people's blood, so that you prevent as much transmission as possible. But if the rates are extremely low, you may not need such high level. So it's a very good question, and it'll depend on the situation we're at next year. But my thought it would be like more if there are a lot of variants that actually show that they don't, that the vaccines are not able to protect or prevent against, then that might be more of an adjustment of the vaccine, which they're already in the works right now.
So if you think about the Clarity patients, and particularly those on infliximab, where you see this attenuated response to natural infection and to one dose of vaccine, one might hypothesize that the immunity will wane rather quicker than those people who are not on those medicines. So we will find that out through Clarity, because these patients are still going follow-up. They still get a blood sample every time they come for their infusions. So we should, within the next 6 months, when it's really relevant, have a good understanding of whether or not there's anything particular for our patients that merits a booster dose.
That's a good point, because again, not all patients are equal and will have the same. It's very heterogeneous, right? And so for the immunocompromised or patients exactly like that, they may actually require boosters.
And one point I want to emphasize for the audience is these questions that are relevant to you, the inflammatory bowel disease community, is relevant for so many different populations. And there's lots and lots of studies that are being done in many different types of populations, but I can tell you there's actually a lot of studies that are not being done in the non-IBD populations. And so the one thing, just to take reassurance, I realize that we can't answer all the questions today, but there are so much research going on, and Clarity IBD is an amazing example of what's happening in the UK. We're doing a lot here in Canada as well, data that you're going to see published over the course of the next few months, as well as a tremendous amount of research in the US, all geared towards IBD. And I know this because we're all involved with these studies. There's been a huge amount of funding that happened through many different organizations to fund this research. And so the IBD population is going to get this type of data specific to them, which I can tell you is going to be extrapolated to many other populations that haven't had this level of study. The one thing I want to do, I just want to ask Charlie a question, and I'm going to try to group a lot of questions that were asked, and it's all around different drugs that people might be on and the impact of the vaccine. And let me just preface the question around Clarity IBD looked at infliximab and vedolizumab. So infliximab is Remicade, or its biosimilars like Inflectra, Renflexix. Vedolizumab is Entyvio. Both of those medications are infusions. And I think that's one of the reasons that they were chosen. Charlie can correct me if I'm wrong, but because people going to infusions, there's very easy access to getting blood samples and studying them, as compared to many of the medications that patients are on, like Humira or adalimumab, which is an anti-TNF therapy like infliximab or Remicade, but is a self-injection. So it wasn't studied specifically in Clarity IBD. Now, it has been studied in other studies, but again, self-injection medications like Stelara, ustekinumab wouldn't have been included. And then oral medications, like if you're on a 5-ASA or mesalamine, weren't studied as well. And so I just wanted to clarify the reason why, infliximab and vedolizumab were chosen. And Charlie, could you give us a little bit of thought on what your thinking is around other medications? First, do you think that anti-TNF has a class effect, meaning that can we extrapolate data from Clarity IBD to people on Humira or Simponi? And then what do you think about drugs that have not been studied at all mechanistically, like a drug like Stelara or Xeljanz or tofacitinib?
So thanks, Gil. So let me just first clarify the rationale behind the study. So we were really testing the hypothesis that anti-TNF drugs would have this effect. And yes, we went for an intravenous drug because patients coming to the hospital, bearing in mind that for a lot of the last year, most patients have not come to the hospital. We've been doing clinics by phone or via telemedicine, etc. And whilst that's been opening up a lot more in recent months, I think that was very shrewd for Clarity. So people were coming to the hospital. And the beauty, as I said before, of doing infliximab with vedolizumab as a control was that they're coming at roughly similar intervals, etc., over time. We have made allowances, of course, for patients switching to subcutaneous Entyvio, which we've been doing over the last 6 months too. So let's look at other drugs. I think that this is very likely to be a class effect for anti-TNFs. There's no real reason, I think, why it should not be. So I would say, whilst we can't say for sure, it is very probable that what we're seeing for infliximab also applies to adalimumab, Humira, or biosimilars, of course, and to golimumab or Simponi. Does it apply to immunomodulators? Well, we know that it does in combination with an anti-TNF agent. And also we see an effect in combination with vedolizumab. So I think we can be fairly sure that there is an independent effect of azathioprine, mercaptopurine, and methotrexate. How big that effect is if someone is taking those drugs on their own, we just do not know because we have not studied that. So I think it's reasonable to assume there is maybe some effect there, but probably it's a bit lower than the effect that we see with anti-TNF drugs and lower than patients who are on both an anti-TNF and immune modulator together. When it comes to other drugs, really we don't know. Ustekinumab, Stelara, or tofacitinib, Xeljanz, we don't have any data to support that within the Clarity study. We are now funded and are about to launch a parallel study to Clarity IBD called the VIP study that Nick Powell is leading in Imperial, but with the same project management team, where we will study ustekinumab, we'll study immunomodulators on their own, we'll study adalimumab, we'll study tofacitinib. And in this study, we're going to target people just after the second dose of the vaccine, because that's where we really want to know what the impact has been. And we'll do a series of mechanistic studies looking at not just antibodies, but also T-cell responses, etc.
And the one thing I would add to that is that there are other groups, like our group in Calgary is doing a very similar study looking at many different drug classes. We expect to have that data out, our first kind of cut of the vaccine data in the summer of this year, to help kind of fill in some of the gaps. Additionally, the group in Mount Sinai and New York recently published in Gastroenterology a study. Now in the US has had an ample supply of vaccine, and so there hasn't been an issue with timing between first and second dose. And the data from the US, looking at a number of different biologics, and it included both anti-TNFs like infliximab, as well as vedolizumab, as well as Stelara. And all of their data, if you get the dose from 0 and 4 weeks later, these were all mRNA-based vaccines, and all essentially had high antibody titers post-vaccine, and that included patients with Stelara. Now, the only kind of challenge with the US data is there's a much smaller sample size as compared to the huge study that was published in the UK. So I still think we need a bit more time to get greater clarity on some of these other drugs.
Yeah, agree with all that, Gil.
That's great. And maybe for Ann or Charlie, well, Ann first, then Charlie, what about steroids? There was a lot of discussion about steroids around the table when we did our clinical practice guidelines. What are your thoughts on whether people who are on steroids should be getting the vaccine, or should they wait to be tapered off?
Yeah, no, good question. So in general, you want to give the vaccine at a time where the person is at the lowest possible immune suppression, if you have any control on that. So sometimes we don't have control over that, but sometimes we might. So for example, if you know of a patient that you're about to start steroids, if you're able to provide the vaccine, in that window period, that's the ideal situation. But we're in real life, sometimes it's not ideal. Extrapolated again from other studies, we know that the certain dosing of steroids might be so high that you may not be able to mount an effective immune response. So so generally we say like an equivalent of 2 per kilo of prednisone, for example, for more than 14 days. So, 1 day of high dose steroids is okay. But if you're on prolonged steroids, high dose, then it's probably not a good time to give the vaccine at that point. But if you have a control over that, then to pick that window. But it goes again, I think that any immune suppressive, right? Like you're not going to get that ideal or optimal immune response. It's not necessarily going to be 0, but in general, if you would be able to avoid the time of high level immune suppression, that's ideal.
So I think the most important thing to say is that all sensible management of IBD does not involve prolonged uses of high doses of steroids. We should not be using high doses of steroids for any more than a couple of weeks. A course of prednisolone should not last more than 8 weeks. That would be good practice across the board. And so get vaccinated regardless is my advice, because particularly actually with the longer dosing interval, you should only be on steroids for one of your vaccine doses. And so almost certainly the effect will be fine after all. So that's my pragmatic answer there, Eric.
Yeah, no, and I think that's reasonable in terms of, that's similar to what I've been recommending. I think it really depends on the individual patient circumstance. So a reminder for patients that we've recommended that if you are on steroids more than 20 milligrams per day, you should be staying home, not going to work, protecting yourself. So if that's the case and you're able to stay home and not expose yourself to potential COVID, I think it's reasonable to wait until the steroids have been tapered a little bit. And the plan is to taper, obviously. I think it's reasonable to wait. But if you have a family member, for example, who has to go to work in a factory, and we know the risk of COVID is huge in certain areas of factory workers and people who are frontline essential workers, I think that you're better off somewhat protected than not at all protected. So I think that's really a discussion that people should have with their physician, their IBD physician, and they can sort of evaluate the risk and the benefit of getting each.
Yeah, and one thing I would add to Eric's comment is not only if you're in that situation, but remember, your family members can be vaccinated too. The greater the shield that you can create yourself. And again, this is in the context of the steroid comments, but really on anything. Like if you got first dose and you're not comfortable, you may not have had a huge response because you're on a drug like infliximab. One way to protect yourself is to ensure that the people around you are vaccinated when they're eligible. Of course, they're going to have their own limitations based on the criteria. But one thing that we're seeing, and this is probably a little bit more in the US, but may eventually come to Canada, is vaccine hesitancy. There are people who are kind of hesitant to get the vaccine in the first place. And there are some people, and we've seen this a little bit more in the US and other regions, that are got their first dose, but are not coming to their second dose. So I think the key is the more of a shield that you can create around yourself, the better protection that you'll have as well.
So, Gil, there was a really nice bit of data that just came out of the UK this week, a very big study where they looked at your ability of passing on COVID if you'd have had just one dose of vaccine, and it's halved by 50%. So this is in the general population. So absolutely encourage those people around you to get vaccinated, because if they even if they've had only one dose, if they do pick up COVID at work or wherever, they're then half as likely to be able to pass it on to you. So it's a really strong argument, that, I think. So one dose, actually, although in our context here is not ideal, for the general population does provide a really good shield.
So very quick questions, again, getting back to special populations. Sorry, Anna, I lost track of that question earlier. But two special populations that are your specialty. Firstly, pregnant women and breastfeeding women. Get the vaccine or no?
Oops, sorry.
Yes, you're
yes.
muted, yeah.
Yes. And in big guidelines, you're always hesitant when there's no data, but there's definitely increasing data. There's been some studies just published in the New England Journal of Medicine. There's pregnancy registries. And we are seeing very high morbidity and ICU admissions in pregnant women right now and during the third wave. So definitely big yes at any trimester, also if lactating or breastfeeding. And that has also been, that message has been laid out by the SOGC. So that's a Society of Obstetrics and Gynecology in Canada, as well as in the US as well. So
and it's now very well established that pregnant women
very well
who get
established,
COVID do not as well. So more severe
Mm-hmm.
COVID if you're pregnant, and increased chance of prematurity in the infant as well. So it would be very important to be vaccinated. And then the other group obviously is children that you and I deal with. There are lots of questions about children in these vaccines. The vaccines are not approved for children. Pfizer is approved for 16 and over, and the others are approved for 18 and over. But I'm understanding from a question, which I hadn't heard about, is that Alberta has opened vaccine eligibility to children born in 2006 to 2009 who are immunocompromised. Gil, were you aware of that?
Yeah, and so people who are like children who are severely ill. And one of the things I was going to say, I think the data from Pfizer has been studied in 12 to 16-year-olds, and I believe, if I understand, and Erica, I'd rather you comment on it, but the data has come out and shown that it is safe and effective in that group as well. And if you wanted to comment on that specifically. Yeah,
well, so Ann, do you want to comment?
Yeah, so they released a media release, I guess, for their study looking at the safety and efficacy for the 12 to 15 years. So this is Pfizer only. And it was very well, it actually, in their media release, it says 100% efficacious and safe and no safety signal. So this was around 1,200 kids, participants at 12 to 15. So from my understanding, this data is going to be reviewed in the coming weeks by Health Canada and NACI. So we should have more concrete data to review. However, the National Advisory Committee on Immunization has always put it as a discretionary recommendation for the 12 to 15 with medical conditions that put them at high risk of severe disease or high risk exposure, et cetera. So, speaking from CHEO, we actually have started in the last couple of weeks to vaccinate our highest risk medical condition children 16 and above as well as case by case 12 to 15. But I just saw that in Alberta, they opened it up to the 12 to 15 a little bit more broadly. So that's going to come up. I think things will change as we get to see the pediatric data in the coming weeks.
Yeah, and we would say as pediatric gastroenterologists for 16 and above, absolutely. If you qualify, get vaccinated. For 12 to 15, having IBD really is not one of those high risk groups where you're at risk for having severe COVID and dying from COVID. So most kids who are 12 to 15, including kids with IBD who are immunosuppressed, do very well. And therefore, we would recommend waiting for Health Canada approval and NACI recommendation for those children. The AstraZeneca vaccine is being studied now, I think, in children 2 and up. So they've gone quite low in terms of the age groups. And so that study is going on, but we don't have the results yet.
I think in Israel also, they have found that the adult vaccination has provided so much protection across the population that they're now thinking they won't need to vaccinate children.
So I think that depends on who you hear in Israel. I think there's a strong argument to be made for us not being able to achieve herd immunity if we don't vaccinate children. And so, yeah, I mean, I think some people in Israel are saying we should already be vaccinating children. So I think, we'll see how this plays out. But for now, children under 16 are not eligible to receive the vaccine, except if there's very special circumstances.
And one point that I want to emphasize for the audience is, like, as for example, Alberta made that decision. So that was the Alberta Health making that decision based on recommendations of Alberta Health Services, which is kind of the operational health authority, based on recommendations, given flexibility recommendations from NACI, and then driven by the results of the Pfizer studies showing safety and efficacy in the press release. And of course, and so this again, before approval. But every province is going to treat this differently, just as they're going to treat timing of second dose differently, which populations they're going to prioritize. So it's province by province, things are different. And it's one of the challenges of communication that we have here on these webinars, as well as on the website, is to know that not everything that you hear is going to be relevant to every province. But I can tell you that once a province does something, others will follow. And we'll see as more data comes out and something like that, you'll start to see others follow. We saw that when we had the first original questions around, should IBD patients be vaccinated even first dose? There were certain provinces that led that way, and now all of them are doing it. One question I had for Charlie was around timing of the vaccine relative to when you take your medication. That was very commonly asked. And one thing I would presume that in Clarity, the antibody, like the blood test was done at what we call trough level. So for example, if your infliximab is given every 8 weeks, you come to your infusion ready for your next infusion, you're at kind of essentially the lowest dose of your infliximab. And that would be the most convenient time to then take a blood sample. Then you get your infliximab infusion and you go home, meaning that I suspect people weren't coming in mid-cycle or other times like that. And so I just wanted to kind of clarify the timing in terms of Clarity, but also, do you have any recommendations around timing of when you get the vaccine and when you should have the infused or injection of medication?
So we have tried to date to look at this in the data, and for the reasons you suggest and a couple of others methodologically, it's just really difficult to work out whether or not there is an impact on the timing of infusion to vaccination, and also whether or not there is an impact on, for example, trough levels of infliximab. Do they correlate with vaccine responses? So we can't answer that. We have taken a super pragmatic approach, which just says, just get the vaccine whenever you are offered an appointment, and that doesn't matter if it's the same day as your infusion of infliximab. It doesn't matter if it's the same day or the day after you're taking your adalimumab at home or whatever. And we've had that advice throughout. We gave that advice right at the start, so that's what the patients have been doing in the Clarity study, and so we're not seeing any obvious impact of that, I don't think.
And that's similar to the literature in the flu vaccine. We reviewed that when we created the clinical practice guidelines, and there were 3 studies from what I remember, 2 in rheumatology, 1 in IBD. And the 2 rheumatology studies really said both sides. They were very small studies. One said do it mid-cycle. One said do it right before your infusion. They had opposite results. And the one IBD study said there was no influence of when you got your flu vaccine during your cycle. So it made no difference. So we felt for the flu vaccine that there was no recommendation to get it at a certain time in your cycle. Whether that holds true for the COVID vaccine or not, I guess we'll find out.
I mean, and you might find, like I saw that a lot of the questions were like, infusion centers are telling you to hold within a few days of the infusion. And I think a lot of that reason to drive that isn't even so much about antibodies levels. Like if you were to get an infusion and the vaccine on the very same day, and then let's say you had, a reaction to the vaccine, like Eric described earlier, you would know, is it an infusion reaction, is it a reaction to the vaccine, or things like that. So often people are just kind of separating the timing out a little bit just to give a bit of space between, two events that might make you feel a little bit uncomfortable.
Yeah, so it might be sensible, for example, if it was your first ever dose of infliximab, that would be pragmatic and sensible.
So with that, I think we should wrap it up, knowing how dastardly late it is in the UK right now. So thank you so much, Dr. Lees, for joining us and staying so late into the morning, I guess, over there. And Dr. Pham-Huy for staying over your dinner hour and staying for the almost 2 hours that we've been doing this. We really appreciated it from both of you. They were both very informative and very understandable talks, is the feedback we're getting from the audience. So with that, we want to thank the audience for joining us again. We will plan on having another webinar next month. I haven't decided on the topic yet, but we will decide within the next few weeks. Please do let us know your suggestions, your comments, any ideas you have for topics, and please leave your feedback at the end of this presentation. You'll get an email with a request for feedback, please. We do read that every month. As usual, we want to thank frontline workers, not just healthcare workers. Most of the healthcare workers now are immunized, thank goodness. But I think the group that I would like to thank particularly are the people who are involved in the factories and the warehouses and have to go to work because they can't afford to stay home. We really do need paid sick leave in Canada, and that's something that has been a tremendous issue and something that physicians are advocating very strongly for across all of the provinces. And we recognize that you have to go to work to feed your families and are putting yourselves at risk. And we greatly appreciate all of what you're doing in terms of keeping us all safe and keeping the food chain alive and everything. If you don't feel well, please don't go to work. Please apply for benefits from the Canadian government. Some provinces are now offering paid sick leave as well. Ontario announced their program yesterday. So please don't go to work if you're not feeling well. But thank you for putting yourselves in jeopardy. As usual, if you find these webinars useful, please do donate to Crohn's and Colitis Canada. Again, I've said this for the past year, unfortunately. And I have to say, Anne, when you said 5th or 6th wave, I heard a collective smack of people whacking their heads against the keypad.
I am so sorry.
But it has been a year since Crohn's and Colitis Canada has been able to do any sort of in-person fundraising, and the Gutsy Walk this year will be virtual again. And that has had a tremendous negative impact, unfortunately, on our ability to fundraise. So if you find these useful, please do donate. You can donate at crohnsandcolitis.ca, or you can text 2222 to donate $25 directly on your cell phone bill. And with that, I wanted to say thank you to everyone. Please do follow us on social media, Get Gutsy Canada. Gil and I have Twitter, you can follow us as well. And then Charlie has Twitter, but also the YouTube channel, as I mentioned, is very, very informative. So please do look us up. And I don't think you're on Twitter, right?
No, not yet, I guess.
Not yet, you should be, you should be.
Maybe I should learn.
People will be
guys.
looking out for you, absolutely.
I know.
But thank you, everybody. We appreciate your time and all the questions that we've gotten, and we will see you in about a month. Take care.